So yeah, morning everyone. I'm Fiona Springall and I'm the Children and Young Persons Learning Disability and Autism Specialist Nurse at the Norfolk Norwich Hospital. So I've been kindly asked to join you all today just to talk a bit about my role, a bit about the hospital passport as well, and obviously answer any questions or queries that you guys might have. And also if you have any feedback you want to give about any experiences you guys have had in the hospital, obviously it's always welcome because it helps shape what we do moving forward as part of the service as well. So, you know, I'm happy for it to be a bit of an interactive session as well. If anyone wants to sort of say anything, I don't know if there's a hand up feature here or just wave if not, and obviously I'll try and come to you guys as well, and we'll kind of go from there if that's okay. Brilliant stuff. Fab. So hopefully is my slide moved on? Has that all worked okay? Brilliant stuff. So just to start off with then, I thought I'd run through just an outline of our team structure here at the hospital, because we're really fortunate to have 3 learning disability nurses employed by the trust. So to start off with, we have Lydia, who is our learning disability and autism lead. Unfortunately, I don't have a photograph of Lydia, hence the smiley face, but she's our overarching lead for the service. So you may see her for some of our paediatric cases, particularly if I'm ever on leave or if it's a particularly complex case, we might work together to kind of support each other and work out the next best steps for the family and the child. But usually Lydia leads our overarching service, so she does a lot more of the strategic kind of part of the service. Below that, you obviously have me. So as I said earlier, I'm the Children and Young Persons Learning Disability and Autism Specialist. So I support children from birth until 18 years old, but typically I don't tend to become involved until the child's probably about between 3 and 5 years, usually because for those younger children, they don't tend to require as much of my specialist input anyway. But obviously it's always a case that we would consider sort of on a case-by-case basis. And then below the picture of me, we have Tara. So Tara's our adult learning disability and autism specialist. So Tara supports patients from the age of 16. So we have an overlapping period of 16 to 18 where both myself and Tara will be involved. And that's to support the transition process. Obviously, we appreciate that transition can be quite a worrying time for families. And it's quite a big step for the child as well to go over to a different part of the hospital and meet new doctors and consultants. So we work together over that period of time to make sure that there's continuity in the care, and also so you get to meet Tara before the child fully transitions, so you know who to expect from the service as I then hand over to her care, if that makes sense. So we have that overlapping period, which has been, you know, fed back has been really helpful for families as well, actually, which is really good. So that is our team. So to start off with, I just wanted to talk about why we're actually based here at the hospital, because I know that many people don't often know what a learning disability nurse is or what we actually do or why we're employed in hospitals. So I just wanted to give a brief outline as to why that is. So it has been recognised that people, both children and adults with learning disabilities and or autistic people, do sometimes receive poorer access to healthcare, and they have poorer health outcomes when they're not supported correctly in hospitals and in the community as well. So our job is to make sure that we are ensuring that children get access to the appropriate services here in the hospital, and also that they're supported to feel comfortable and confident when they come to us, because we do really appreciate that coming to hospital can be quite a scary thing, both for the child and for the families, because it's a very complex and overstimulating environment. So the aim of the role, as I sort of briefly touched upon, firstly, it's to improve patient and parent carer experience when they come to the hospital. Many families that I've supported have sometimes had a negative experience when they come to either this hospital or a previous hospital. So my job is to work alongside yourselves and obviously the child as well, to make sure that we're making the right adjustments to help support them when they come back to the hospital, and to help rebuild those positive experiences with us to then ultimately help the child moving forward. It's also to improve patient safety and to improve patient access to the hospital care and the services. So as I just mentioned, we are aware that obviously sometimes accessing the right service can be a real challenge, and it's a real tricky system to navigate at times. There's lots of different people involved in different services. So when it comes to the Norfolk Norwich Hospital, my role is to work alongside you guys to make sure that you're getting access to the right services when you come here. My role is also to reduce the risk of health inequality and those barriers to healthcare. So that's around working with the staff to help sure that they're empowered and to make sure that they are aware of how best to communicate with your child and how to support the child's behavioural needs if they have any, and just to help manage those anxieties and stuff when they come to hospital. And overall, the aim of my role is to make sure that we have a person-centred approach to care. So it's about placing the child at the centre of everything that we're doing, and obviously the family's voice as well, to make sure that that's at the centre of what the acute hospital are doing for that child, and then ultimately leading to the correct health outcomes. Are there any questions so far? No? Fabulous. So this is a brief kind of outline of my role. My role is really big and diverse. So I have, in the next couple of slides, I've broken it down into some sort of smaller sections to kind of explain that. But the three kind of main categories of my role is, of course, the practical patient support, which is what I do the most of. But I also have an element of education and training in part of my role, and there's a strategic element as well. And this is also the same for our adult team as well, by the way. Just, oh, sorry, my phone's ringing. Yeah, this is also similar for the adult team as well. So you can kind of marry it across to what you might expect when your child transitions to adult care as well. Thank you. Sorry, my colleagues just grabbed my phone. So with regards to the educational part of my role, so that is a sort of a third of my role. So we deliver training to staff, and which is something that I know from previous family feedback has been identified as a lot of families have felt that staff need additional training, which is why that's then been sort of included. So I have a mandatory training program for our nurses and doctors in the hospital. So they get training from myself about learning disabilities and autism. So what is a learning disability? What is autism? How can we adapt our communication needs? What are the sort of health inequalities or barriers that our children might face when they come to hospital, and what can we do to help overcome this? So I deliver that training yearly for our staff. But alongside that, I also do bespoke training for particular areas of the hospital as well. So in the past, if we've had a complaint come through for a particular department, for example, I've then done training following on from that complaint to really focus in on what went wrong and what can they then do moving forward to help improve things. So that's where, as I said earlier, having feedback from you guys as the family members is so important, because it does help shape then what I do and then ultimately what the service does moving forward. So with some of that bespoke training, a department I worked with quite closely when I first came into post was the emergency department, because that was an area that we noted was a real challenge for a lot of families and children coming through. So I did a lot of work around that. I also should have mentioned earlier, sorry, that my role came into post in January 2019. So it's almost about 3 years old having this service here at the Norfolk Norwich. So still relatively new in comparison to our adult service, which has been here for about 11 plus years. But yeah, so kind of when the role was set up, it was really about listening to you guys as the family members and also the staff and experiences, just to make sure that I could then deliver the training and the correct support to those areas. I also do training outside of the organisation. So we work closely with the University of East Anglia, who obviously train our student nurses. But I've also done bespoke training sessions around other areas as well. So always happy to reach out and do sessions such as this today, but also with our local other Norfolk providers, such as schools or other community teams and things as well, just to make sure that we're all kind of working along the same page really, and we've all got the right kind of expertise and awareness of what's happening at the hospital. And I also educate staff at a ward or department level as well. So I work really closely on a one-to-one or a very small group basis with particular staff members, particularly if we've got a child with us who's with us for a long admission, for example. The staff might need some extra support around addressing the child's communication needs, or perhaps the child's displaying some behaviour that might be perceived as quite challenging by some of the staff. So my role is to then work alongside the staff and obviously the families to help make sure we're meeting the child's needs correctly alongside that process. So that's the educational part of my role, which say is kind of one element of it. So I'll also go on to talk about the strategic part of my role. So this is when sometimes I'm burrowed away in my office and people might not see me for a little while. So one thing that I do is I run regular audits. So I look at the admissions, both through the emergency department at the hospital and also the inpatient stays for our patients. And I will review those admissions, so have the patient notes and look through them. And part of that is to identify what's working well for that child and, you know, for the staff members, and also what's maybe not working quite as well. And are there any things that we're concerned about that we need to maybe address through training moving forward? So audit is a really big part of the role as well, and that does help us again shape how the service continues to be delivered. So that's one aspect of kind of the strategic element of what we do. I also sit on various boards and committees, both within the trust and outside in the community. And the aim of that is to make sure that the voice of our patients is being listened to. So that the patients' needs of children and young people, and obviously adults as well with learning disabilities and or autism, are being addressed and included in conversations when it comes to developing and implementing change, both within the trust and within the community as well. And I also work really closely alongside various teams and departments within the hospital and externally as well, actually, to implement change and to continue to improve services. So an example of what I'm doing at the moment is I'm working alongside our play specialist team to identify a really clear pathway to make sure that they're seeing children at the correct time and they know when they need to refer to myself or when actually it's things that they manage really well as part of the play team. Other implementation sort of projects I've done work alongside, as I said, the emergency department, and we implemented some new pathways as part of that. And I'm also looking really closely at our theatre pathway at the moment as well. So children who come in for surgery, and working alongside the anaesthetic team and the theatre team to make sure that there's pathways written up and sort of documented into policy that they have to follow to help make those pathways a lot smoother for our families and for the children as well. So again, it's a very big, diverse part of the role, and it does really vary, obviously, dependent on how the system and the service is kind of looking at the time. But it does make change, and obviously having the voice of you guys as family members is really central to that, and obviously the patient feedback as well, because that then helps us know who to focus on, what teams to focus on, and what to then do to help improve things.
Can I ask, Fiona, we have got a question in there from Maria.
Yeah.
It says, do you offer training for GPs or community practitioners?
So I work really closely alongside community practitioners. GPs are a little bit of a harder nut to crack, I've found, just regards to it's such a diverse population. There's obviously so many GP practices in Norfolk. But what I do is I work really closely with our local clinical commissioning group who oversee that umbrella, if that kind of makes sense. So as part of that, it then gets disseminated through. But at the moment, unfortunately, due to capacity means I wouldn't have the capacity to kind of do it bespoke with GPs, but there are conversations happening within the community as to how best to reach out, because we do appreciate that sometimes it's not always the most accessible environment, and there are adjustments that GP practices could make to help children when they come to them. So I'm always open to conversations with, community practitioners and stuff to help kind of that pathway move forward, if you know what I mean.
Maria, did you have any comments that you wanted to add to that?
Oh, thank you. No, I was just, I think to make the whole journey of the patient better, starting right in the community, it would be really important to just raise awareness of the different types of learning disability and the different degrees of autism as well, so that reasonable adjustments can be made and hopefully prevent hospital admissions. So I think it would be really helpful to have that training out in the community. I just wondered if that was, who would be doing that? Because I appreciate you can't do it. You're based in the hospital.
No, I absolutely agree though, Maria. I think it's about getting it right from the first port of call, which is, like you say, usually the GP before it gets to the point where the child's admitted to hospital. It's certainly something I'd be happy to feed back, if you're happy for me to our local CCG, because they would be the people that would have those conversations with the GP practices. I'm aware that Lydia, who's our lead of the team, she does do GP training for the trainee GPs that are then coming through and getting jobs. But I think, there is certainly a need for bespoke GP practice training, for those people who are already in post. But we do training with like the medics and stuff who are newly qualified, who would then go on to become a GP. But I think there's a system-wide need there as well, isn't there, where actually the whole service needs to be looked at from the community perspective as well as, moving into the acute. But that's really helpful feedback there. And if you're happy for me to, I'd happily pass it on to Tracy, who's our overarching sort of lead for the CCG.
Thank you.
Lovely. Fab. Any other questions before I move on? No? Fabulous. So I'll go on to talk about our patient support, which is obviously the biggest part of my role and the best bit, because I get to work alongside all the children and families. So again, I've broken this down into different sections because it's, again, a very diverse role and part of the role that I have. So I can obviously try and help support children when they access Norfolk and Norwich for any reason. So whether it be an inpatient admission, an outpatient appointment, surgery, or an A&E attendance, my role would obviously cover that. And there's things in place to help support that. So to start off with, I'll talk about inpatients and the kind of things that I can help do for our inpatients when they come to hospital. So obviously many of our inpatients will be staying on either Buxton ward or Coltishall ward, which is our CAU ward. So we do only have two main children's wards here at the hospital. So the main aspect of my role when it comes to our inpatients is to, someone coming into the room. The main aspect of my role with regards to inpatients is to review and monitor the admission. So as part of that, I would obviously, again, I check in with yourselves as the family members and the child, but also provide guidance and advice to staff as well. So this is where our hospital passports come into play as well, which I'll go on to talk about a little bit later. So for our inpatients, I can also do bespoke assessments. So if we find that actually we're potentially worried that maybe some of the child's needs aren't being met or recognised correctly by some of the staff, whether it be their communication need or how they express pain, for example, then I can be involved and I can run bespoke assessments with the child and family to help identify that. I also identify and support with adjustments on the ward. So whether this be that the child might require a quieter place, unfortunately we can't always guarantee a side room, but we can try and arrange a quieter bay environment, for example. If the child has particular sensory sensitivities, it's always really important that I'm then aware of that and I can then help the team make adjustments for that moving forward. Or it could be that the child might benefit from having some bespoke information made, so like accessible or easy read information about their care. So only a couple of weeks ago, I made a social story about having a chest drain inserted for one of the children I was supporting. And I actually made it using Frozen characters, as in Disney's Frozen. And it was about Olaf having a chest drain and how it was going to help him when he came to the hospital. And that really helped the child understand and engage with what her treatment was going to be. And it just made it a bit more fun and visual and more comfortable for her. And she actually helped me make some more of the social stories moving forward because she had a few different interventions undertaken during her time with us. And that just really helped her have a bit of ownership about what was going to be happening to her, but also feel more comfortable and confident and have a bit more knowledge about what was going to happen as well. So that's a little example of some of the things I can do to help our inpatients. And obviously another part of that is to care plan as well. So I will write bespoke care plans about the child when they come to hospital, and whether that's for an emergency admission or an elective surgical procedure. So if your child's due to come to us for surgery, it may be that I reach out and make contact, or people can obviously contact me directly and we can talk about what adjustments the child might need for that surgery. So it could be that they would rather have a gas induction rather than a cannula because they're quite worried about needles, or it could be that they might struggle with waiting in hospital. So we need to put them first on the theatre list to then make sure they get seen a bit quicker. And all of those things I would then type up into a plan, which I then send out to the surgeons, the anaesthetists, the doctors and nurses here on the ward. And it gives them a bit of awareness of the child's needs before they meet them on the morning of the surgery. So that then just helps streamline the process for the child when they come to hospital. And also for our inpatients who are with us for a long time, I'll write those bespoke care plans to then make sure staff are aware of the child's needs and they can sort of grab them quite quickly and know immediately what adjustments they need to make. So for our outpatients, again, outpatient care, it's really variable. As we know, every child is so individual. So what I do will depend on the child's needs. So for some outpatients, they don't need my input at all. They come to our clinic really frequently and they absolutely sometimes quite enjoy coming to see us, so it's absolutely fine. And I don't need to be involved. But for other children, some families might request my support. And for some families, it could be something as simple as just asking whether I can ring the department in advance and say that they're obviously coming into clinic and just requesting that they either have a bit of a reduced wait or maybe a quieter place to wait. Or for some children, they find it easier to wait on our park. So we've got a lovely playground outside. So we can arrange for them to wait outside and then be called straight through from the playground into the clinic room rather than having to wait in the busy, noisy environment. Or for other children, they prefer to wait in the car and then be called straight through to clinic. Or sometimes they go to Costa and have a hot chocolate if they're really lucky with their family members. So that's certainly another adjustment that we've arranged recently. And we have got a really great team in our outpatients departments. We have a wonderful healthcare assistant called Sarah, who sometimes calls families in advance as well if she's aware that the child might have a learning disability and or is autistic. So she might ring you guys and say, actually, you know, what can we do to help? So sort of a similar role to mine, and where she can then make sure those adjustments are made in the actual setting. But for other families, they might need my presence to be there for the actual appointment. So some families ask me to come along to the appointment, and sometimes doctors ask me to come along to the appointment as well, particularly if they feel that the child's maybe going to have to come back for maybe surgery or a scan in the future. So they might ask me to come and sit in just so I'm there at the whole sort of pathway and the whole journey for the child. So it could be that the child meets me in that clinic appointment, or I might already know them from a previous admission. And then it helps just kind of join the dots really and make sure everyone's aware of the child's needs, and then we can start planning early on for that upcoming intervention rather than it suddenly happening with really short notice. Also, sometimes families request for me to be there because they might feel like they just want someone there to advocate on behalf of the patient or themselves, and they might be a little bit worried about what the doctor's going to say. So I can obviously be there as well to help on behalf of that, and also to provide that information to the child to help them understand as well what's happening and why they need to have these things done. So I can also, with regards to the care planning side of things, as I said, we can provide accessible information for our outpatients as well. So it could be around, coming in for a scan or coming in for a blood test, and we can provide that information and help, start that conversation quite early for the child. And then moving forward, it helps the child feel more prepared and more confident when they come to the hospital.
We have a hand up. Maria, did you want to ask a question?
Hi again. If a child with a learning disability or autism comes through A&D, would it be reasonable for the parent to ask the casualty officer to call the learning disabilities team at that point?
Absolutely. Yeah, no, absolutely. Sorry, that's really good because I hadn't put emergency, I hadn't put a bit about emergencies on here. So thank you for bringing that up. It's a really good question. So yes, absolutely. So I can support children in the emergency department as well. As I say, I have done quite a lot of work with the emergency department to try and make sure that they can make adjustments, because obviously, unfortunately, accidents and becoming unwell doesn't happen 9 to 5, Monday to Friday. It does happen out of hours as well. So we need to make sure that the A&E department's equipped to make those adjustments. But absolutely, if it's during my working hours, and if I've got my hours at the end of the presentation, but it's always worth saying to them, actually, can you guys ring Fiona or call the learning disability team? They've got our contact details. They've got a poster up with our contact details on as well, so you can call us down and we can help with any challenging situations that you might be facing, or just to help express on behalf of you guys the child's needs and making sure that the right adjustments are made. Our emergency department has got a quiet room which they've developed for children with a learning disability and autism. So they are getting quite good at fast tracking the child through to the quiet room and then fast tracking them through A&E where possible. Obviously, when they've got really clinically unwell children, it's a little bit more tricky, but they will try and get you seen as quickly as possible. And they've also got a lot of sensory resources down there as well that they can provide to the child. And another project that we've done recently with A&E is making sure children get a sensory pack. So it's like a little bag of about 3 or 4 sensory toys, which are given to the child to then keep. And we developed this off the back of the pandemic, because obviously a lot of our resources were having to be thrown out because we couldn't clean them. So now we have various things like little pots of slime or little musical toys or colouring or packs of cards, where you guys can choose what you think would be best for your child. And it can then be given to the child on arrival to A&E, just so they've got something to take the mind off what's going on and just something fun and nice, and they get to keep it or take it with them if they're then admitted to the ward as well. So it's just a little pack just to help make it a little bit nicer and a bit, it helps soothe them and distract them and kind of meet some of those sensory needs. So that's another big project I've done with A&E. But yeah, absolutely, if you are in A&E and you feel like you need any additional support, or you'd like me to come down and review your child, then please do let the team know, and they can obviously contact me, or you can contact me directly. I'll give you again my numbers at the end of this presentation, but you can always reach out to directly refer to me as well.
Brilliant, thank you.
No worries. So continuing on with I'll just remove the slide, the outpatient kind of work I do. So before COVID, I used to do home visits. I would offer a one-off home visit for families whose child found it particularly challenging to come into hospital. So some children may have refused to get into the car to come here because they are very anxious. So they might have had a challenging experience in the past, which meant they were really frightened. So before COVID, I was able to come out and meet the child at home or at school, and just allow them to get to know me in just a fun way, just come home and play. I've been known to bake cakes with children just to help build that rapport with them before they then meet me at the hospital. I have a great job. But yeah, so it's just about building that relationship at home in their own environment. And it also helps me begin to assess the child and kind of get an understanding of, their communication needs and how well their understanding is of where they might need to come to hospital. But then, of course, COVID unfortunately hit, so I was unable to do that anymore. So we had to think of different ways as to how to approach this. So the first way, obviously, for our children who may not feel more confident to come to hospital, it was to do things over Zoom or Microsoft Teams, which I have been doing and still able to do if the child would engage in that. But we also had to think of ways to have a protected space for the child when they do come to the hospital to feel more confident and have that play and desensitization implemented. So the trust really kindly allowed me the time and space to run a preparing for hospital clinic, which is something that I still run at the moment. So the hospital clinic is a protected clinical time to allow the child to have desensitization and preparation for a whole variety of hospital procedures. So this could be for a blood test, for example, or an X-ray, a scan, an EEG, all of the kind of clinical interventions that children might get referred to us for. And having this protected time means that I can bring the child and family up to the hospital. They can meet myself in a really positive and comfortable environment. for example, on the picture we've got in front of us is one of our clinic rooms, which we've turned into a sensory room, and that's something that we can do here at the hospital. And the child comes up and we just, for the first visit, we just play and just have a nice time, whether it be outside on the park, or if there's any particular games they enjoy doing, or activities such as art and craft activities, or some children just like coming up and playing on like the Nintendo Switch or the iPad, or just having a chat about things. So the first visit's usually like that, and we just kind of run it really casually, and it's at the child's pace. Obviously, it's important to remember that this can only be done for interventions that aren't clinically urgent. Obviously, if the intervention needs to be done urgently, then we have a much shorter time scale. So unfortunately, we can't, have the beauty of weeks and weeks of desensitization and prep, but there's other things we can do to support with those sorts of situations. But I'll go on to talk about the kind of process for that. So the preparing for hospital clinic process, as I said, we've got the initial visit that would be undertaken with myself, and that would usually be a play or engagement session, but maybe with some of our play specialists as well might be there, just to help the child meet some new faces when coming to the hospital. And then the next visit, if we feel that the child is feeling comfortable enough, we might introduce some of the clinical equipment. So I'll use the example for this of preparing a child for a blood test, just to make it a little bit easier to visualize. So on the second visit, if we feel the child is at a good enough place to be able to have, say, some of the equipment in the room, perhaps in a tray just on the side, we might just have it there just so the child can kind of see it. There'll be no pressure for the child to touch it or to kind of be involved with it, but it's just there, and it just helps the child kind of recognize it. Obviously, some children might dive straight in and be like, wow, what's this? And want to talk about it and kind of want to look through it. So this sort of arrow sheet that we've got in front of us, it does work at a very different pace dependent on the child. But then as we're moving forward, we would then begin to incorporate the equipment into play. So I'll just go back one slide. You can see in the corner, we've got our Medi Teddy in the corner of his little scrubs on. So we have medical bears, and we also, children might bring their own teddies or their own dolls from home, and we can begin to incorporate the blood test, for example, onto the toy and allow the child to begin to sort of do the test themselves on their teddy to help them gain that understanding of what's going to happen. And it also helps them from a sensory perspective begin to understand the sensations of what a tourniquet might feel like, for example, or what happens, so where does the blood go, how does it go into the bottle, where does it then go after that, etc. And then moving forward, we would then incorporate use of that equipment on the patient if they felt comfortable to. So usually by that point, the child is able to allow us to perhaps just wipe their arm with the clinical wipe, or maybe put a tourniquet on. And that, again, is used at their pace. So if the child says, actually, no, like I'm really frightened, or we get an inkling that they're finding it quite challenging, we would then stop, go back to playing, and then the visit can be stopped at the child's pace, because we wouldn't be forcing children to have this done. And then moving forward, we would then perhaps attempt the intervention. So we might attempt the blood test. And if, again, we find that by a certain stage, say after it's been wiped and the child may have noticed that the needles come out, they become distressed, we would then stop the intervention, go back to the play, and allow that to be the ending note for that visit. But we would continue this until the child does feel confident enough to then have the intervention done. And I've done this many times for lots of blood tests, but lots of various other interventions as well. So it could be, say, if the child's having an X-ray, part of the visit could be just to go down to the X-ray room and just have a look at the equipment. I've had children have X-rays of their teddies done before, so they can just get an idea of what it looks like, what it sounds like, and just get an idea of the whole environment. It's obviously important to say that sometimes it doesn't work, and sometimes the child's own anxiety is still too much to kind of overcome with some of the interventions that we do implement here. So then with that, then I would then pass it on to the appropriate teams in the community, and obviously speak to the families at the time and talk about our options moving forward. But luckily, usually it's a really high success rate, because we do have the beauty of working for as long as the child needs. So I have worked with some families for over a year to achieve a blood test, but it's then meant that when the child's come back, they've had it done really quickly, and they've only needed one pre-visit, and then they've come back and had it done because they've remembered the process. So as long as we have the beauty of time and we don't have to have it done clinically urgently, then we do have the scope to kind of implement these sort of visits. Again, with regards to kind of referrals for this process, sometimes doctors refer directly to me and say, actually, I know that this child needs a blood test, can they come to you for a few pre-visits? Or families can self-refer as well for this support. Are there any questions about the clinic? No, that's fine. Perfect. So now I'm going to talk to you guys about hospital passports. So I think a few of you may have heard of them before, but I've just gone through and I've included the whole passport so we can move through kind of each page and just talk it through. So the hospital passport is a document and it outlines the most important information and personal details that we would want staff to know when the child comes to hospital. So it does include things like the medical information, but it also includes things like the child's likes and dislikes, their communication needs, personal care needs, etc. And the idea of the document is for it to be used within hospital, but the family members can have a copy themselves, but we also keep a copy saved on our system here at the hospital. And it means that when the child comes to hospital, families don't have to keep repeating their story. It just helps have that document there to then pass over to staff and say, actually, this will help you understand my child's needs, and this is how you can best support them when they come to hospital. So the idea is it helps staff gain a better understanding of the child, and then they then know what adjustments to make moving forward to help them when they come to hospital. So some common questions I think may have come up, so I've popped them into this presentation, is so who completes the passport? So the passport can be completed by anybody. So family members and carers and obviously the patient themselves can complete it themselves. But also I can complete the passport obviously alongside you guys if you feel it would be helpful. So I've done this sometimes when the family's been on the ward, I've gone down and sat with them and we've gone through it together. Or sometimes families might begin to complete it, but they might then phone me with just a few questions because they might not be sure about what sort of information to put in certain sections. So we can do it over the phone, or of course we can do it over Zoom and things as well. And sometimes the community professionals do complete it as well alongside families. So community nurses or the school paediatric nurse advisors may also be included in completing it or might complete it directly with yourselves. But it's always centered around the child and the family. So you guys would be the central hub of the completion of it, but we would obviously support you guys with doing that because at the end of the day, you know your child best. So it's really important to obviously have that voice put into the hospital passport. So who keeps a copy? So as I said earlier, family members, the patients and obviously their carers would keep a copy at home. So if you were to come up to A&E, for example, and bring it in with you, then you've got it with you. And sometimes I've heard families do share it with other professionals as well. So the child might take it to school with them, or they might share it with other like nursing professionals in the community and stuff as well, and the GP practices as well, just to kind of make sure it's there so then staff can access this and find out about the child's needs. We also keep a copy in the child's hospital notes, but obviously it's important to make sure it's updated regularly. And if any changes happen at home, then in the passport, then obviously an updated copy is sent over to us so when we can make sure it's all kept updated. And I also have an electronic copy as well saved here, here at the hospital. So I have got a central file of all of the children that I've supported who have a passport. And that then means that when you come to hospital, obviously you may not always remember it, particularly if it's an emergency situation. I can then print it off and then share it with the teams, just so there's no pressure on you guys having to remember all of the paperwork when you're obviously in a really busy situation. And how to access one. So I can post a copy out or email a copy out, or like I say, if I meet you guys face to face, I can obviously give you guys a paper copy. So if there is anyone obviously after today's presentation that would like one, just let me know or let Nicola know. I think I have sent a copy to you, Nicola, haven't I?
Yes, you have.
Yeah, so you can forward it out afterwards. That's fantastic.
Absolutely.
And on the end of it, it does have my contact details and my postal address as well, in case anyone wants to post or email a copy back over to me as well. And also you can ask the departments if you're in hospital or if you pop in for an outpatient appointment, you can always ask the teams and say, actually, can I access a hospital passport? Can I grab a copy? And I do have link practitioners in those areas who should be able to help and support you guys with that. But if not, ask them to give me a call and we can get a copy sent down to you as well.
You have got a hand up with Maria.
Sorry, it's me again.
No worries.
I was just wondering, can this passport be used for adults with learning disabilities as well?
Yeah, yes, absolutely.
Brilliant.
Yeah, so the hospital passport was actually kind of born in the world of adult care, to be honest, because obviously I think paediatrics haven't used it as long as the adult side because my role hasn't been in place. So there's been many years without a paediatric learning disability specialist here at the hospital. So the hospital passport is NHS recognised across all NHS trusts. So not just Norfolk, not just the Norfolk and Norwich, it is across the board. So even if you go to Paget or King's Lynn for adult care or paediatric care, it is quite a widely recognised document. So absolutely it can be completed and carried with you and then passed on. And obviously Tara, who's our adult learning disability nurse, can also help support with the completion of those as well.
Okay.
No worries. So I'll go through what the passport looks like. Apologies if some of you guys have obviously seen this before, but I'll just go through. I've put the whole thing on here into the slide so we can all kind of have a look through what it looks like. So obviously the first page and the second page really is quite self-explanatory. So obviously the front of the document, as you can see, it's got the traffic light coded system. And this just helps staff identify what are the most important things they're going to need to kind of grab and go in that emergency situation. So as you can see, the first page is kind of, what the child would like to be known as, but also date of birth, contact details, etc., and obviously any allergies and religious needs and ethnicity, etc. So that's quite a simple one to complete. Usually I don't get many questions about that. And usually that's something I can easily complete my end, because obviously we have all of those contact details on our system here at the hospital already. So moving forward, the next two red pages we have, there's a few different kind of categories to this. So the first part is existing medical conditions, which of course, again, can change quite frequently. So it's important to have it up to date, sort of updated as frequently as possible. But then we move on to, there's a specific section around heart or breathing problems, or if the child's premature. And that's something that our paediatric nurses said would be helpful to add to this passport, just because they obviously see a lot of children come through with those needs who may then go on to have a learning disability. So it's something that they just decided to include, because quite often a lot of our children who have most complex health needs would have needs related to that. And then the next box is the box that I find most helpful, because it's around how to support the child with medical intervention and what adjustments they might need. So I often find families ask me, we're not sure what to put in this box, and sometimes it's a little bit confusing, or they're a little bit uncertain about what to have. And sometimes that's because actually if the child's never had a blood test before, then you don't know how we're going to best support them to have it done. So in that case, we kind of think about the child's pre-existing needs. So if we know that a child has needs regards to sensory stimulation, if they get overstimulated very easily, then obviously for any intervention in the hospital, we're going to need a quieter environment. We're going to need possibly a reduced waiting time, and we're going to need a calmer, more approachable sort of outlook on how to do this, and a little bit more flexibility. So we can put those kind of adjustments in there. We can also put, if it's helpful to have both parents present, for example. Obviously at the moment with COVID, the overarching rule of there's only allowed to be one parent present, but we can override this rule as part of the learning disability team. There has been NHS guidance implemented, which does say we can have two parents. So as long as we're informed, we can then make sure the department's aware, and then they will make sure that's accommodated for you all. So if it's important to have both parents present, then obviously that's important to put it in that section of the box. But also it may be that some children actually don't mind having medical interventions done, in which case you can pop it in there, but it might just be that they prefer a particular approach. I had a child refer to me recently who likes to have a certain song sung when they have an intervention done. So that's all stuff we can put in there. And the doctors and nurses are usually really accommodating actually, and don't mind, singing along to Mr. Tumble when we're doing an anaesthetic or whatever. So, all of those little things, which might seem like really small things and things that you might think, well, that's not important. Actually, it's always worth putting it in there, because we will take any information we can to help make it a better experience for the child. So just underneath that, we've got, obviously, is there any risk of choking for eating and drinking and swallowing? Because obviously that's a very high risk thing. So we would want to know, obviously, about that sort of in the earlier stages of this document. And then moving on to the next page, we obviously talk about communication needs, and it's also important to look at pain recognition as well, because we know that often pain isn't recognised as quickly as it could be for children when they do have learning disability or are autistic. So it's important to talk about, how does the child express pain? How can we best support them to express it as well? So do they need prompt cards which say that they're sore or a little bit sore? What sort of language does the child need to use? So some children might express their pain as saying that they're sore rather than I'm in pain, or they might say it's a hurt, or they might use completely different language. So including that in there helps staff then recognise when the child is trying to express those needs. And again, with regards to sort of meeting communication and pain needs on the wards, there are resources we can implement and work alongside the families with. So like I say, we've got flashcards that have different smiley faces or different colour codes, which can help the child express it. Or we have like a body map where the child can point to the area of the body where it might be hurting them, and then it helps them then express, where the pain is. But again, it's all bespoke on the child. It depends the child's needs. So we can then kind of work alongside you guys to identify that. Below that is around, what does the child need to help keep them safe? So it could be that they need both parents present, just to help them feel more comforted and safe, or it might be that they have a particular teddy or blanket which helps them feel more safe when they're in hospital, or it could be that actually the child might attempt to leave the ward, and obviously we wouldn't want them to be put in an unsafe position. So it's important to have that documented on there, so then we can make sure the right supervision is implemented on the ward to help the child when they come to see us. And below that, it's got what can make me worried or upset, and then how to help me. So we know that some children do feel very anxious about coming to hospital, and there can be certain things that can make them feel more anxious. So we would want to make sure this is documented on here so the staff are aware. But then also, if the child does get to a point where they're quite worried, what can we then do to help make them feel better? So is it better to leave them with mum and dad? And is it best, some families prefer that, or would you prefer that we came in and try to implement, distraction and play to work alongside the child to help them feel a little bit more comfortable when they're staying in the hospital?
Can I just ask, do the doctors and nurses get asked to look at these?
They do, but I think I've included in this presentation, actually, we have a one-page version of this because this is obviously quite a long document. Yeah, I think I have included it on here. But yeah, they are, and this is part of the training as well that I deliver to them, is to look out for this. And I think because it's being used more frequently now, it's becoming a bit more like inherent into their practice. So they're seeing it and they're like, oh, hang on a minute, I know what this document is, this is going to help me. So then they look at it. But yeah, I think I go on to talk about our one-page version because that's obviously the snappier version, which is a bit easier for doctors to look and say, right, what do I need to know? Because this is great if a child's with us for a while, or if we know they're coming in and we've got time to read it before we meet them. But if it's an emergency situation like an A&E attendance, people don't have time to read through this lovely 12-page document.
Brilliant, thank you.
No worries. So this page, again, it's quite self-explanatory. So it's got obviously GP contact details and then any other community professionals that might be involved. So that's just helpful for staff to kind of link up if they need to as part of an admission, so to the school, or if you've got a particular community nurse in place, or if you're under the starfish team, for example, it then helps us kind of know who's involved and we can then share information as required. And then the next page is around medication. So the old passport used to have a full list of the child's medication on it, but we actually decided to remove this because medication changes so frequently. It was actually risky having that on there. So we've changed it to any emergency PRN medication, so any medication that the child would have as required, so in an emergency situation. And the kind of idea of this is for children who might have epilepsy medication, for example, or epilepsy care plans, and then it can be included and then obviously updated as those reviews come around from the neurology department, for example. But it also talks about how the child takes their medication. So again, we understand that taking medication isn't always the nicest thing for children to do, and many children don't like to do it. So it's about what approach can we then take as a hospital to help them when they need to have medication on the ward. So I've got a child at the moment who will only take tablets. So we're having to make adjustments to make sure that the tablets he needs when he comes to hospital is in tablet form rather than a liquid, because I think in paediatrics, liquid is often the go-to. So it's just about knowing there's little things that the child needs, and then it helps us then make those adjustments when they come to see us in the hospital. And at the bottom, it just says about whether there's any specialist care plans. So for example, if a child has an epilepsy care plan, just make us aware of it in that box. And then obviously the actual care plan can be attached to the end of the document, and then it's all in one place. So the amber section is obviously stuff that is still really important to know, but it's not as critical to know as some of the earlier things. So again, it's quite self-explanatory, but it explores things such as the child's personal care needs, any problems they might have with their sight or hearing, their mobility needs, and also their eating and drinking needs. So this is kind of the day-to-day stuff. So if the child's with us on the ward, it helps us just get to know them a bit better and know what level of support they'll require from us as a hospital. It then moves on to talk about any aids or just like sort of equipment they might need. And again, if we have this document before they come in for an elective stay, for example, for surgery, we can make sure we've got the right equipment to support them when they come to hospital. Also talks about going to the toilet and how we can best support the child with that need, and also the child's sleeping routine, because obviously children may have to stay on the ward overnight, and that's quite a challenge in itself because the wards are very busy and very overstimulating a lot of the time. So if we understand the child's usual sleep routine, we can then try and implement things, whether it's certain music, certain lighting, etc., to then help them feel more comfortable when they come to hospital. And then this is the final page. This is my favorite page, is the likes and dislikes, mainly the likes bit. So I always complete this bit first, particularly when I'm completing it with the child, because that's the bit they obviously get most involved in and really enjoy telling you what they like and what they don't like. So I always go to this page first, because actually if I know what a child likes, that usually really helps me begin to build that rapport with the child, because I can talk about their interests and then begin to engage with them, and then that helps moving forward when we begin to talk about the more clinical medical things. But also, again, it's really important to know what the child doesn't like, because then we can make sure that we don't do those things where possible, and just to make sure if there's anything that they find really challenging, like busy environments, for example, we're then aware of that and we can try and avoid that where possible. I often find that children put hospital at the top of the don't like page, which isn't always the best starting point, but it's absolutely fine. So yeah, I often then say, what about hospital is it you don't like? And then it then helps us understand a little bit more, whether it's the smell of hospitals or the hospital gowns or the people in the hospital. It then helps us kind of make those adjustments moving forward. And then the final page is about routine. So this is an extra page again that was added after a review, because obviously we know that some of our children, particularly children who have autism, have quite particular routines. So if we know what their usual routine is at home, we can try and mirror that as best as possible when they come to hospital. Obviously, hospitals are very institutionalized environments. So you get fed at a certain time, you have your medication at a certain time, and it's quite rigid. So our role is to obviously break that barrier and find out if the child has toast at 11 o'clock at night, we can get them toast at 11 o'clock at night, and we can kind of work around what their usual routine would be at home. So not all families complete this page because some of their children may not have quite set routines, or they might not feel it's appropriate to complete for their child. But often it's really helpful just to know anyway, like what the bedtime is usually, or what time they usually get up in the morning. And it just helps us then be aware of their needs when they then come and stay with us on the hospital. So I briefly just touched upon the emergency admission plan. So this is the one-page plan that I was talking about earlier. So we're aware that the hospital passport, as wonderful as it is, and it has obviously all the information we need, it is about 12 pages long, which in an emergency situation or when the ward is really busy, staff unfortunately don't have time to read. So off the back of that, we then developed as part of a learning disability team our one-page emergency admission plan. So this document is completed by myself or by Tara or Lydia in the Learning Disability team. And we use the information that we get from the hospital passport, which is obviously usually completed by yourselves as the family members, to then create this one-page version with the most crucial information involved in it. So you can see by the side, we've got things like medical needs, communication, pain recognition and management, anxiety and support, etc. These boxes can change. So some children may not have needs around anxiety and support. So we can swap this box out for another topic that might be more relevant to that child. So this document is usually completely blank and completely adaptable to meet the child's needs. And this just means that we can have it on front of the notes, and it's just a really snappy bullet pointed out list of the child's needs, which staff can then access. We can also save this document with the A&E department, so this can be accessed out of hours. So the child can have this saved on their electronic records. So when a child's booked into A&E, staff can access this and print it out, and then it's popped in the A&E record, so then the A&E staff can see this. And because it's electronically held, it means they can access it at any time of day or night. So there's no dependence then of our team being on site, because obviously we're unfortunately not here all the time. So it does mean that they can access it when we're not here, which is obviously proved to be really, really helpful for some families. Because again, it just helps them then not have to keep repeating themselves and explaining their child's needs to every professional that they meet.
Right.
Are there any?
Sorry,
Yeah.
I was just going to ask a question. Can this passport be used at other hospitals like Adam Brooks or Great Ormond Street?
Absolutely, yeah. So the emergency admission plan is only a document that I've seen used obviously in our trust. It's something that we've kind of developed, but I would always say if you've got, I always send families a copy of it, and there's no harm in taking this with you as well. But the hospital passport is recognised across all NHS trusts. So Great Ormond Street use it, like say Adam Brooks as well. It's really worthwhile taking it with you. And if I've completed one of these for your child, for example, I will always send you the copy of it so you can take it elsewhere as well. Because even if it's a case that you've gone to the GP, you might say, actually, can you look at this first before you meet my child, and then it just helps them get an understanding. But I'd say there's never any harm in taking additional information to different hospitals and different community professionals as well, if it's going to be deemed helpful.
Yeah, because it can be so overwhelming trying to get a child to the place and then have to sit and explain all the history to everywhere. That would be brilliant. And we've also got Maria with her hand up as well.
Yeah.
Are you there, Maria?
I'm so sorry, my mouse would not hit the unmute button.
I've done that loads of times.
So I think just from a parental perspective, one of the things that we worry about most is when our children become anxious, they sometimes become, that anxiety manifests itself as aggression. And in mainstream schools in particular, that challenging behaviour, that perceived challenging behaviour is not fully understood. So in an environment where, I mean, I understand the hospital passport is absolutely fantastic, but our children will become anxious and may become aggressive. How do you manage that on the ward?
Yeah, so I mean, The ideal world is that we would understand what could make the child become anxious or aggressive prior to coming to the hospital, or when they arrive on the ward before it happens. So we would want to make sure that we've made the right adjustments to help the child remain calm and comfortable when they're with us. But equally, I appreciate it doesn't always happen. So in that case, we would obviously work alongside yourself as the family members and the child to then listen to you guys and what approach usually works best for you when at home, if there is kind of a main approach we could do, or if there's any particular adjustments we can make, such as changing the environment, providing sensory resources, etc., to help the child then self-soothe and become less overstimulated by the environment, if that's kind of the cause to it.
Yeah.
But then moving forward, if it's something that we find is occurring quite frequently on the ward, I can undertake a functional assessment of the child's behaviour, which is where I would, the staff would complete a small chart each time something happens. They would look at what happened before the child became worried or anxious or displayed a behaviour that might have been challenging. What was the behaviour that they displayed, and then how did people react to that, and what happened afterwards? And then what we do is we then collate all of that information, and then it helps us identify any key themes, or were there any main triggers, or did something happen at that time of day which then caused that behaviour to happen? And then that helps us understand, why is the child appearing like that on the ward? Why are they feeling more worried and anxious with us? And then what can we do to help change that? Obviously, as I've said throughout, it's not a one-size-fits-all approach. We do have to, work around the child and the family. The other thing it might be is, for example, if we're finding that the child's getting really distressed when they're having their physical obs taken, like their blood pressure taken, for example, we're seeing that that's kind of a main trigger for the child to become distressed. We would look at, do we need to be taking it every 4 hours, or actually, would it be clinically safe to do it less often? There are lots of things we can do to kind of think outside the box around our approach to then help keep it as smooth and more comfortable, visit and stay for the family and the child.
Yeah, thank you. That's excellent.
No worries.
Sorry, could I ask, because I presume some families might even have problems to actually get the child to get in the car if they know that they're going to see a professional or hospital. What advice would you give to the parents if, like, say, for example, they needed to go to A&E, but they're having such a battle before they even get into the car?
Yeah, so when it's an emergency situation, it is much more difficult, because obviously if it's for like a blood test that's in a few weeks' time, obviously I can work alongside yourselves as the family members, and we can implement things like social stories about coming to hospital, or the home visits or the pre-visits, etc., and building that positive relationship and trust with it. But when it is the case of actually they are clinically really unwell and you need to get them in the car to hospital, that is obviously a much more challenging situation. I think actually moving forward, really great feedback. Perhaps having a social story about coming to hospital for an emergency admission would be a really good thing to have, perhaps something that could be developed. I'm just going to write that down, because that's something that perhaps could be sent out to families, and they could kind of have it on the back burner. But I think also, if there is a worry that your child might become like that when it's an emergency situation, it's about kind of recognizing that earlier and thinking, actually, my child struggles to come up for outpatients, and they struggle to come to the hospital. So what work can we do now before they're in the emergency situation? So to kind of rebuild that trust with the hospital. And that's where coming to like the Preparing for Hospital clinic can kind of help with that, because it helps build trust with coming to the building of the hospital rather than just a specific department. And I have done work like that before with families where they've come up just to see me for play, and then we've gone for like a walk down to A&E, so they've been able to go and have a look at A&E and get a feel for what the environment is like. And that's then helped moving forward that actually they recognize the environment, they've been there before, they had a positive experience there, so it makes it less anxiety provoking. But of course, the other challenge is if the child's feeling poorly, they're going to possibly be even less willing to kind of it's going to be harder for them to process what's going to happen and what needs to happen and stuff. If they're already feeling unwell, or if they're in pain, they might be quite distressed anyway, so it does kind of add another situation. But I think if it's something you guys think would be helpful as well, having like a social story that can kind of be kept by families, but actually now we're going to go to the hospital, we're going to go to this place, which is A&E, with like photographs of the department, maybe some of the staff and doctors that you might meet. I do have a link practitioner in A&E who was going to start doing some social stories around having like an X-ray in A&E and stuff like that. So I can perhaps ask her to develop one around just coming to A&E. And actually it could be like, you're poorly at the moment, so you need to come here and be seen by the doctor. Obviously it would have to be kept quite vague, because we don't know why the child would be coming to A&E, but just about having photographs and stuff to help them. But I think
that would be something that we'd be happy to share as well on our Facebook group as
that
well.
Would be amazing. I'll feed that back to our link team and ask, because I think actually moving forward, that's hopefully a really good option to kind of have on, you know, in the bank, really, in case you needed to have it. But again, it does depend on the child, because some children may not respond well to a social story. It may not be something that meets their needs. So it is difficult, because obviously every child is so individual. And if it is a case that you're like, we need to get in the car now to come to the hospital, that is a real challenge. And that's where doing earlier prep work just about coming to hospital would then helpfully help that moving forward.
I was thinking about the teenagers as well, because obviously that's a different sort of age group, isn't it? When they might be already too anxious to go and engage with school. So again, that's another very hard time for the parents.
Definitely. Yeah, and I have been in conversation with our community side, because I am seeing an increasing number, particularly since the pandemic, of children who are more anxious than they possibly were before COVID hit, just about leaving the house. And obviously that's not something that I can directly support if it's an overarching anxiety around multiple things, because I am only based here in the hospital, unfortunately. But that is then where I can then link in with other community teams and refer on, obviously with families' consent, if they're happy for me to. Because I think, it is a real challenge if a child is anxious about going to school or other places. It's not as easy as just coming up to the hospital and having a positive experience here. It's actually a longer term need, isn't it, that needs to be addressed in the community at home with support. And obviously we've got services like CAMS and things, but waiting lists for those kind of services are unfortunately really long at the moment. So it is about having those conversations with, you know, from my perspective, with those other teams in the communities to see what we can do. And that is something that I've raised recently, because we are seeing an increasing number of that, unfortunately.
I meant it in regards to coming into hospital and needing to have an appointment, but it's geared at the teenage year side of it as well, isn't it? Whether there's an app or
absolutely. There is an app actually. It's mainly for children coming in and young people coming in for surgery, where they can it's like a virtual reality. It's called My Little Journey. Again, I can send you guys the information to circulate about this, but it's been filmed at the hospital, so you kind of work through it on the app, and you can kind of press a button and work through the ward, so you can see what it looks like. And I know they've got that for Buxton Ward and like an anaesthetic room and theatres. I don't know if they have that for the emergency department at the moment, but that is an app that obviously the young person can carry on their phone. But also the preparing for hospital work I do can be for teenagers as well. So it doesn't have to be, you know, about teddies and sensory lights and bits and bobs. You know, we can we can come up and do sort of gaming and stuff like that, instead, to kind of build that relationship and allow them to have a voice as well and say actually what they are worried about and build that trust with us. So yeah, absolutely, it's something across the board up to the age of 18, obviously from my role's perspective, that we can do. So yeah, so I've just realized it was quite aimed at children when I spoke about it, but it is for teenagers as well. Absolutely.
Brilliant.
No worries. Right, so this is just our referral process. So the referral process, there are sort of many ways that people can refer to our team. So obviously hospital staff can refer to us directly. So sometimes that comes through the form of, you know, clinic letters, or they might refer through our electronic system. And sometimes that's quite early on before the child comes to clinic, perhaps if they know they're going to come in for a few more appointments, the doctor might refer over. Or it could be while the child's on the ward, the nursing staff refer directly to us just to say, you know, they've come into hospital, you know, we need a little bit more of extra support around a communication need, for example. So they might then come in to see us. Patients, parents and carers can obviously self-refer as well. So on the next slide, I think I've got my contact details. So people can refer to me directly if they've got a concern about, you know, there's an outpatient appointment coming up, or the child needs a blood test and they think that they might benefit from having some desensitization support, then that's absolutely something that we can implement. And the referral can come through telephone or email. So there's kind of no big barriers and referral forms that some services have. And then community professionals, including schools, the NHS community teams, and obviously the private sector as well, can also self-refer in. So I often get referrals from specialist nurses, for example, or the schools directly, like head teachers, or the school nurse might sometimes refer in to me because they've spoken to the family and they think actually a bit of extra support from our team could be helpful. So that's another route that comes in. We also don't necessarily require a confirmed diagnosis, because we do appreciate that obviously the timescale is really long to get that diagnosis. So as long as the child is presenting with the needs and is about to go onto the pathway for that, then that's certainly, you know, we would reach out and be able to help support where we can with regards to the child's needs when they come to the hospital. And as I mentioned below, obviously we've got telephone, email and letter. So there's no kind of, as I say, there's no big referral forms and big long processes and call centres and stuff that you might find with other services. You would come straight directly through to us in our team. So obviously if we're ever out of the office, you can leave a message on the phone and then we'll get back to you, or you can drop us an email as well. And these are our contact details. Now I have no idea what the time is. Oh, I've been an hour. That's almost perfect timing, look. Yeah. So here are the contact details. And obviously the last slide is if you guys have any questions, please feel free to fire away, or any feedback as well about any experiences you've had at the hospital, good or bad, it's fine.
So whilst other people are thinking or wanting to talk, I'll just give my feedback, because you've supported my daughter and myself for over a year, and it's been a completely different experience for us. So we've been going since we're about, well, from birth really, to be honest, and then finding you, it made it so much easier to go to neurology appointments with our daughter having epilepsy. It's a constant thing of going up to the hospital. We know you're there if we need you for our emergencies as well. And yeah, obviously the iPad really helps, the music, and Fiona does sing. And she also runs very well after your child. We've had a few experiences and it's been absolutely amazing. So thank you, Fiona.
Oh, thank you so much, Nicola. No, yeah, it's a pleasure. But no, thank you. That's really lovely feedback.
No worries.
I also thought I should probably just say, obviously we work Monday to Friday, so we're not here weekends. And overall, their service cover usually between about 7:30 till 5:30. So I usually do about 7:30 till 3:30 or 8 till 4 shifts, and then Lydia works 9:30 till 5:30. So we've got kind of that lengthy cover, but I do flex my hours around the family and the child. So if a child's coming in at 7 for surgery, for example, and I need to be in, I can come in early, obviously where I can, and kind of accommodate that. Or if a child's coming in later and would prefer to have an appointment after school, for example, if I can get rooms sorted and stuff, I can work a bit later. So it is quite a flexible kind of service, but unfortunately we're not here weekends and evenings, of course, which is a real shame, but there's only 3 of us, so well, only one of us per side, so yeah. Any other questions or anything else I can obviously support with at all?
I was just going to ask Fiona, so what happens if a child comes in over the weekend? What support would be provided at that point?
Yeah, no, really good question. So obviously a big part of my role is working alongside the departments to empower them to be able to make these adjustments. Ideally, the wards should be making the correct adjustments anyway without my service. So in a way, we're almost trying to put ourselves out of a job in a funny way, because actually the job is to empower these wards to do it, which they are certainly getting there. So with regards to A&E, for example, we have the emergency care plans, which we can save on the system, which they can access. We also have an alert system, which we can put on the child's record, which says if they have a learning disability and or autism. So this alert will sit on place on the child's record permanently, and that just means that when children are accessed or admitted to hospital, the staff are aware of that need at an earlier stage, so it flags it up. It also means that when a child's being booked for any appointments, it's flagged up to the teams, and then they can obviously make those adjustments moving forward, which is really helpful. And then also we have, with regards to the ward staff, because of the training, staff should be thinking ahead, thinking, actually, what adjustments do I need to make for this child? Obviously, having your passports is really helpful as well, and having a copy saved in the notes, and also having a paper copy if you remember to bring one in. That then helps them, and they are all trained to know that they should be looking at this and listening to you guys as family members. And we also have a risk assessment which staff complete, which then helps them understand what adjustments might be helpful to make next. So it talks about, the child's communication needs and any anxieties they might have, and then it signposts them as to what would be a helpful adjustment to make. So it's almost like getting our advice when we're not actually there. It's like a flow chart, if that makes sense, for them to kind of know what best steps to make next. But yeah, of course, unfortunately, I'm not always here. It's just me covering the paediatric side. So it's really important to obviously make sure staff on the wards and in those departments are empowered and are understanding what to kind of do to help the child. But obviously, if there were ever any concerns, they often refer in, and obviously once the weekend's passed on a Monday, I can go back, because I get alerted when children are admitted, so I can then go back and review Monday morning as soon as I'm in, and obviously check in with the families if there are any concerns, and families can obviously contact me over the weekend. I'll pick it up Monday when I'm back and come back down. But yeah, unfortunately we're not a 24/7 service, but we've tried our best to kind of mold the process of the hospital to help make it a better environment anyway, without us directly needing to be there.
Brilliant.
So could I just ask also, what's the process of actually having a hospital passport done? Because I mean, my son, he hasn't got one. I've never even heard of this before, which I think is actually brilliant. My son has actually had quite a few hospital admissions through A&E. Wow. Obviously that's slowed down a bit now. It's more to do with his immune system and stuff. But obviously he has had times where he stayed in the hospital for like say 3-4 nights. And you know, it was kind of like it was difficult because every doctor like we met, every nurse we met, we had to like go over these things, and it would definitely be helpful to have something, as you say, on place, so then they can actually look and see, you know, rather than us just doing this and this, you know.
Yeah, no, of course, Kirsty. No, so with regards to you getting a passport, obviously Nicola can send out them via email to you, and you can complete one. Obviously, if you have any questions about completing it, and my number is on the back of it, so you can always give us a call, and I can help you complete parts of it as well. We can also then, obviously, once it's done, you can send or post a copy to me, and I then create that one-page one that I showed you guys earlier. So that's something that I would then type up with the information you've given me, and then we can get that saved on the system. So if you drop me an email with your child's sort of name and date of birth and stuff as well, I can allocate them on our system, and then say once you've got the passport, then just complete it or give us a call and we can complete it together. But yeah, it's a really simple process. There's no kind of big formal exciting like process you have to go through, really. You can just
that'd be brilliant. I mean, like I say, he hasn't actually come into hospital, thank goodness, because we did have a period where it was kind of like maybe like once a month or once every other month he was coming in, and it was mainly he's obviously had immune system like an extra course of injections compared to a normal child, because they found that his immune system cells were actually quite low, and this is why he's been so prone to, he was always getting like the sicky kind of bugs, and then like high fevers as well. But obviously since having these boosters, I mean, the hospital were brilliant picking that up, you know, on CAU, and actually saying, well, actually this child could benefit from having these. And I am safe to say it's actually working really, really well. He's not getting it as frequent now, you know, so
that's
but
really
definitely
good.
that I've always found, you know, I can't fault the hospital, even though Thomas's needs haven't obviously been mentioned, but nurse and staff are usually so good with him, like getting him to have these things, because I mean, one of the things that he has, needles, he's not actually too bad, which I'm quite impressed about, but it's the like when they have to do like the pulse and stuff, he hates that little clip being put on his finger, you know, and the nurses actually naturally just come up with these games to kind of get him involved and actually get him to like have it on his finger so he weren't scared anymore. So
that's lovely to hear.
Really
that's really great to hear, because like I say, part of this role is obviously to empower the staff to know to, you know, make those adjustments and make it fun. So it's lovely to hear that even though, you know, he's not had a formal diagnosis and you've never had to explain that, they're still thinking outside the box and thinking, what can we do to make it good? So that's really lovely feedback. But please do get in touch if you want to talk about the passport further, or you know, feel free to have a little look, and we can have a look together as well.
I've also just put the office email address for SENsational Families, so if anyone wants a copy, feel free to just email in and I'll pop one out to you as well.
Please. Any other questions?
I don't think we've got any more on there.
No, it's fab. Well, thank you all for inviting me. It's been great to speak to you all.